Non-protein nitrogen compounds. Non-protein nitrogen is the removal of proteins from a specimen before it's analyzed. It is quantified spectrophotometrically to convert nitrogen to ammonia. The reaction is done with Nessler's reagent to produce a yellow color. It is useful information by analyzing a specimen for individual nitrogen-containing compounds. Non-protein nitrogen compounds are urea, creatinine, creatine, and ammonia. Urea is present in the highest concentration in the blood. It is the major excretory product of protein metabolism. It is formed in the liver from amino groups and free ammonia, which is generated during the protein catabolism, which is called the urea cycle. It is termed BUN for blood urea nitrogen. The biochemistry process releases nitrogen that is converted to urea and excreted as a waste product. Synthesis in the liver is when urea is carried to the kidney by the blood and filtered by the glomerulus. Measurement is used to evaluate renal function, to assess hydration status, to determine nitrogen balance, and to aid in the diagnosis of renal disease and to verify adequacy of dialysis. Urea can be measured in the plasma, serum, or urine. The reference intervals for adults in the plasma and serum are 6 to 20 milligrams per deciliter or 2.1 to 7.1 millimoles per liter. 24-hour urine specimen is 12 to 20 grams per day or 0.43 to 0.71 moles of urea per day. Azotemia is an elevated concentration of BUN. Uremia is a very high plasma urea concentration accompanied by renal failure, which is fatal. There are three categories for causes of an increased plasma urea: pre-renal, renal, and post-renal. Pre-renal azotemia is a result of reduced blood flow. Some causes of this are congestive heart failure, shock, hemorrhage, and dehydration. Decreased renal function causes an increase in plasma urea concentration as a result of compromised urea excretion. Some causes of this are acute and chronic renal failure, glomerulonephritis, and tubular necrosis. Decreased plasma urea includes a low protein intake and severe liver disease. Plasma BUN is decreased during late pregnancy and infancy as a result of increased protein synthesis. There's a chart with just those same causes that I just stated. Also, the differentiation of the cause of abnormal BUN is aided by the calculation of the urea nitrogen per creatinine ratio, which is 10 to 1 to 20.1, 20 to 1. Uric acid, which is the next non-protein nitrogen, is a product of catabolism of the purine nucleic acids. It is filtered by the glomerulus and secreted by the distal tubules into the urine. It is reabsorbed in proximal tubules and reused. It can cause painful inflammation in joints and tissue. It is transported from the liver to the kidney. In small amounts are secreted by the distal tubules into the urine. Urate is insoluble at a pH of 7. It is saturated as a pH greater than 6.8. It is measured to confirm and monitor treatment of gout. The final breakdown of purine metabolism. In the Caraway method, it's the most common method used to measure uric acid. It is also the method that is based on oxidation of uric acid in protein-free filtrate, and it also lacks the specificity. Methods during uricase is more specific and used exclusively in clinical labs. Uric can be measured in heparinized plasma, serum, or urine. It is stable after red blood cells have been removed. Hyperuricemia is a result of overproduction of uric acid. Hypouricemia is less common than hyperuricemia and is secondary to liver disease of the Fanconi syndrome. Creatinine, creatine. Creatinine is formed from creatine. Plasma creatinine is inversely related to glomerular filtration rate, which is abbreviated the GFR. It assesses the renal filtration function. It is synthesized in the liver. The daily creatinine excretion is reasonably stable, and it is used to determine the sufficiency of kidney function. The creatinine clearance measures the creatinine eliminated from the blood to the kidneys and uses the GFR to gauge renal function. The Jaffrey method is used to measure the creatinine, and specimens used are plasma, serum, or urine. Plasma creatinine concentration is elevated. GFR is decreased, indicating renal damage. Muscle disease, such as muscular dystrophy, poliomyelitis, hyperthyroidism, and trauma, plasma creatine and urinary creatinine are often elevated. The plasma creatinine is elevated. Plasma creatine is not elevated in renal disease. Ammonia is produced in the deamination of amino acids during protein metabolism. It is removed from circulation and converted to urea in the liver. Free ammonia is toxic, and it is present in low concentrations in the plasma. Ammonia is also produced in catabolism of amino acids and by bacterial metabolism in the lumen of the intestine. It shows useful info in the hepatic failure and Ray's syndrome and inherited deficiencies of the urea cycle of enzymes. There are two approaches that are used for plasma ammonia measurement. The first one is the two-step approach, which is where ammonia is isolated from the sample and then it's assayed. The second step is a direct measurement from the enzymatic method, or the ion-selective electrode. The ammonia reference values for an adult in plasma is 19 to 60 micrograms per deciliter, or 11 to 35 micromoles per liter. The 24-hour urine specimen for an adult is 140 to 1500 milligrams, and then 10 to 107 millimoles per day. In a child, which is 10 days to 2 years old, for plasma, it's 68 to 136 micrograms per deciliter, or 40 to 80 micromoles per liter. Ammonia's, the highest concentrations are neurotoxic. In hyperammonemia, it's associated with inherited deficiency of the urea cycle enzymes. And that's all of the non-protein nitrogen compounds.